So thank you everybody for joining us. This webinar is brought to you by the VEDS Movement, a division of the Marfan Foundation. And the topic is living with an ostomy and VEDS. This is a personal perspectives panel, and we're really excited to have you here with us watching this webinar. This is recorded, so you can revisit it at a later time if you'd like to watch it again or share it with any of your friends and family or your doctors. So it is recorded. I'd like to introduce two panelists tonight. We have Dr. Iris Wang and Dr. Victor Chedid. Dr. Wang is an assistant professor in the Division of Gastroenterology and Hepatology and is a general gastroenterologist with a focus on disorders of gut-brain interaction disorders, including irritable bowel syndrome, functional dyspepsia, and chronic abdominal pain. She studies GI disorders in addition to research on the pathophysiology of gut-brain interaction disorders, testing of pharmaceutical therapies, and cross-discipline techniques such as gut hypnotherapy, positive psychology, mindfulness, and biofeedback at the Mayo Clinic. And Dr. Victor Chedid is an assistant professor of medicine at the Mayo Clinic in the Gastroenterology division as well. He is subspecialized in inflammatory bowel diseases such as Crohn's disease and ulcerative colitis, as well as motility. And he has a specific interest in the care of LGBTQ patients with IBD. He will be heading the LGBTQ IBD clinic at Mayo, which will start seeing patients in July of 2022. We're really grateful to both of them for being here with us today, and we'll turn it over to them in a second. We also have three personal perspective panelists from our own VEDS community tonight with us. We have Aaron Sander, who is also on our VEDS Movement Steering Committee, Darine Abboud, and Heather Dixon, who have all had personal experiences living with a colostomy and VEDS, or with an ostomy and VEDS. So the way that this webinar will work today is that we are going to start with Dr. Wang, who is going to share some information about some of the gastrointestinal problems and complications that can come with VEDS, and talk a little bit about how those are addressed and things to watch out for. And then she'll turn it over to Dr. Chedid for more information specifically about ostomies. And then we will introduce you to our personal perspective panelists. They'll each introduce themselves to you, and we'll have a really awesome Q&A at the end. So stay tuned, and I'm going to go ahead and hand it over to Dr. Wang. If you have any questions during this presentation, you can put any questions in the Q&A box, and we have time tonight to get to as many as possible. So thank you so much. I'm going to go ahead and stop sharing my screen. Dr. Wang? Oh, and I forgot to introduce myself. I'm Katie Wright. I'm the director of the VEDS Movement.
Can you hear me?
Yes.
All right.
I see your screen.
Perfect. So thank you, Katie, for the invitation. And it is my pleasure tonight to share some of the research we've done in the past about how bowel disorders and vascular EDS interact. So a brief outline of our talk tonight. I'll give a brief word about vascular EDS. Why are there symptoms in these disorders? And what are the bowel perforation risks, and how can they be avoided? And then I will turn it over to Dr. Chedid to talk about the options for ostomy and how do these different options differ. So Ehlers-Danlos syndrome, as I'm sure all of you are aware, comes from a defect in collagen. So it's a COL3A mutation that is autosomal dominant and ends up with a defect in type 3 collagen. This can impact the lungs, the skin, the intestines, and blood vessels, leading to tissue fragility overall. The GI symptoms that are commonly associated are actually mostly associated with hypermobility subtype of EDS. These include hiatal hernias, reflux, gastritis, abdominal pain, feelings of distension, nausea, vomiting, constipation, evacuation disorders, and particularly pelvic floor dysfunction. However, in the vascular EDS subpopulation, you can see all of these symptoms in the hypermobility in addition to issues with colonic rupture. So the diagnostic criteria for vascular EDS, I'm sure you're all aware of, so I will just leave this slide up for reference for a brief moment. But note that the major criteria include spontaneous sigmoid colon perforation in the absence of bowel pathology. So there's nothing wrong visibly with the bowel and nothing has been traumatizing to it, but the perforation happens on its own. In terms of the vascular malformations, I have this brief picture of what a normal angiogram looks like, and in contrast, a 40-year-old patient of ours with vascular EDS who has kindly agreed to let us share these images. And what we're seeing here is that there's a dissection in the abdominal aorta that is also quite tortuous. And so in comparison to this straight shot tube coming down the abdomen, we're seeing a twisting tube with a dividing line in the middle where the intima or the lining of that vessel has torn. This is another patient with vascular EDS showing an abdominal aortic aneurysm that's quite large, and this certainly contains risk for rupture. But coming back to the GI symptoms, which is what we are talking about tonight, the question is, why is the GI system involved at all? Well, as you guys are aware, collagen and extracellular matrices defects will actually impact all tissues, right? And this causes tissue fragility in the intestines as well. This structural instability can also lead to pelvic organ prolapse and pelvic floor dysfunction, which then begets constipation and worsens pressures within the intestines. This then increases the risk of organ rupture because one, there's backup, and two, the tissue itself is already fragile. There's also the impact of tortuosity, these twisting, which then causes more constipation and can cause more buildup, and then dilation of vessels, right? Because the blood vessels are tortuous as well and have higher risk of becoming damaged and causing local lack of blood flow, which then makes the tissues even more fragile. So it's a lot of circuitous reasons and not just one single reason why the GI system is at particular risk in vascular EDS. There's also some thought that there's impact on inflammatory cells in the GI tract. There's also the problem of chronic disease, as when one of these things kind of occurs and you're aware that there's a chronic disease, there can be increased sensitivity to paying attention to these organs, and there can be a dysregulation of what we call the gut-brain axis, which is where the central nervous system and the enteric nervous system kind of miswire, and sometimes signals become more intense than they have to be, such that kind of pain sensations or sensations in the GI tract that don't necessarily have to be felt become extra alerting to the brain. So we looked at in the past, back in 2019, a symptom survey of national EDS and Marfan syndrome patients. And I'm sorry, this is not our research. This was done by a different group in 2019. And among the patients with vascular EDS, I'm sorry, this was with all patients with Ehlers-Danlos. And focusing on these patients, you see fairly common symptoms of irritable bowel syndrome, dyspepsia, as well as heartburn, chronic idiopathic nausea, dysphagia, which is trouble swallowing, and bloating. Looking at vascular EDS patients at the Mayo Clinic GI clinic, so these are our patients that we studied back in 2020, we saw that there was, we looked at 68 patients, 40 of whom were women with vascular EDS. And we saw that 57.1% of them had undergone a prior abdominal surgery. We saw that there was a large percentage of both upper and lower GI symptoms. The numbers here high is for nausea and heartburn, as well as abdominal pain. Bloating is up there as well. The other lower GI symptoms that are particularly concerning are constipation and diarrhea, though one of these patients actually had both because they were concomitantly diagnosed with IBD or inflammatory bowel disease. When we looked at what these patients underwent for investigations, we saw that a number of them, about 82%, had undergone some sort of imaging, and about a quarter had undergone some sort of endoscopy. Of the patients who underwent testing, 91% had abnormal imaging, but from the endoscopy procedures, only about half of these were abnormal. This is kind of important to keep in mind for a little bit later. For surgical history of these complications, though, we've seen that vascular EDS patients have, surgery for GI complications. We've seen aortic repair, we've seen colectomy, small bowel surgery, as well as cholecystectomy. In the vascular EDS population, we saw 27% incidence of spontaneous intestinal perforation, not just at the sigmoid colon, but including all of the intestines. 47% presented with colonic perforation as the very first gastrointestinal sign, so they didn't have any other GI symptoms prior to this perforation. Reperforation rates ranged from 41 to 53% in patients who had an initial perforation. The risk of perforation during endoscopic procedures was cited as high as 9.4%. However, the big caveat here is that this data was generated a very long time ago, back when endoscopic procedures were still done with different techniques. So before, air was used to blow up the colon in order for us to see very well. And now that has been replaced with carbon dioxide, which has a lower risk of causing perforations. In addition, because of this data, fewer endoscopic procedures are actually being done. And so there hasn't been a lot of new studies to say how safe kind of newer endoscopic techniques are. So I put that number out there, but it is not meant to be significantly alarming. So addressing colostomy reversal. So what happens if you do have a perforation? What are some considerations to keep in mind in thinking about getting this ostomy taken down? There's not a lot of data out there about this, but I do want to point out some of our data, which shows that hernias are present in about 49% of the vascular EDS folks that we looked at in our clinic. We saw that there was a number of ventral hernias. So these are sort of at the site of previous surgeries. We also saw that post-operative hernias accounted for about 66% of all these hernias. And so the point here is, yes, reversal can be done. There is kind of that around 50% rate of potential reperforation. And then to be aware that having a surgery and the post-operative chance of a hernia is present because of that collagen defect. So how do we prevent perforation? It's very hard to say, but there are a couple of things we can do to play it safe. Evaluating the arterial vasculature, knowing about what the risk of perforation is if there is a big aortic aneurysm, etc. Monitoring for nutritional deficiency, so making sure that the tissues are able to have as much nutrients as they need to maintain health. Avoiding trauma, collision sports, and actually avoiding routine colonoscopy and elective surgery because, again, of that post-operative risk for poor healing. With the routine colonoscopy, that caveat again is that there is that higher rate of perforation, but that is generated with older data and a kind of a technique that's not really used anymore. However, patients and yourselves with vascular EDS, you still need colon cancer screening. So what are some alternatives? Cologuard testing is probably the safest way to go. So this is tested by a stool sample, but needs to be done with more frequency. And so it can't be once every 10 years with Cologuard testing. CT colonography has been thought about as an alternative before, but know that actually air insufflation needs to happen during this exam as well. And in fact, they probably need more air than we do during a colonoscopy in order to see very well. So that actually also increases the risk of perforation. I would say Cologuard is probably the best way, or some sort of fecal blood testing, or the FIT test. But our asterisk here is that anyone with increased family history of colorectal cancer needs more invasive screening procedures. And in those instances where there's a higher risk of colon cancer, colonoscopy is actually not an unreasonable way to be undergoing that screening. The last thing that I'll leave you guys with is that not all perforations are the same. So we'll hear from our panelists later about their stories and their experiences. But I want to mention that perforation symptoms can really vary. So it can be chest pain if there's a higher perforation, abdominal pain can happen. It can happen very suddenly and severely after some sort of procedure or trauma. But those are kind of what we call macro perforations or big perforations. Micro perforations, on the other hand, are very small leaks, can occur spontaneously, and they tend to occur more, these tend to be the more predominant types. So with a microperforation, generally the symptoms come from the consequence of that leak. So either your body closes off that leak and forms a little pocket of infection or an abscess that then leads to persistent pain in this localized area that may present like a mass, fever, shaking because it becomes infected, or it can form a fistula if left long enough where the intestinal contents leak either into other organs or out of the skin. However, a microperforation can then turn into a free perforation as well if the abscess doesn't form. And this leads to that dramatic symptom of peritonitis, which is irritation of the peritoneal lining, which causes sudden worsening of pain, some temporary relief once that perforation occurs, and then builds up of worsening symptoms. Depending on where the location is, symptoms may change. This may come along with symptoms of sepsis or shock, which is fevers, low blood pressure, and a high heart rate. I'll turn it over now to my colleague, Dr. Chedid, to talk about the ostomy options.
Thank you so much, Dr. Wang, and thank you, Katie, for having us this panelist. I'm just going to share my slides. All right, so basically, Dr. Wang went over the underlying causes of perforation in vascular EDS and symptoms that are pertinent to GI symptoms and also patients with vascular EDS. I'll just go over an overview of what are the ostomy options. And basically, there are several surgical options that a patient who presents with a colonic perforation related to vascular EDS that can be offered. Most commonly, they can offer total colectomy, which is removal of all of the colon, maintaining the rectum, and later on creating an ileorectal anastomosis. But the leak rate of the ileorectal anastomosis can be high, so it's around 50% leak at the site where they suture the small intestine, which is the ileum, to the rectum. And so when a patient will be undergoing an ileorectal anastomosis, the discussion has to be had and the decision has to be made between the patient and their doctor as to whether or not this leak rate is accepted, and if that risk is going to be accepted by the patient and the doctor to pursue that type of surgery. Intestinal reperforation rate after segmental resection and anastomosis or repair are usually significantly higher than those after a total colectomy. So meaning if there's a perforation, let's say in the sigmoid colon or any section of the sigmoid colon, and that's just repaired without maybe taking out the colon, sometimes the risk of reperforation of that colon will remain more elevated than removing the whole colon. The safest approach for such for presentation of perforation is still not known, especially because many of the research studies out there have small number of patients. That's because of how you all know vascular EDS is a rare condition. And so, as we said, the optimum treatment is unclear. Some folks go for primary repair of the perforation. Some folks go with primary repair and the diverting ileostomy, allowing the site to heal. And some folks will have a resection of the segment, will have what we call a Hartmann's pouch, and I'll show pictures and I'll go over that in a few slides. And other folks will go with the total abdominal colectomy, meaning removing all of the colon with an end ileostomy or an ileorectal anastomosis. So let's go over the anatomy. Mainly, right over here, we can see the normal colon. And in this area, we can see that sometimes somebody can have a perforation somewhere in the sigmoid colon, for example, here. So with surgery, they might end up removing the sigmoid colon, and then they would end up with colostomy, which is a healthy bowel tissue that is brought out to the skin, and a Hartmann's pouch, meaning the rectum is sutured up and is left as a pouch. Now, sorry, I'm using the annotation. So there we go. Okay. Now, this is how a colostomy would end up looking. So before you have a continuity of a colon, then when the segment is removed, the colostomy is brought to the skin, and there'd be a colostomy bag overlying that area to collect the stool. In the colon, there are several sites where a colostomy can be performed. There could be a descending or sigmoid colostomy, a transverse colostomy, or an ascending colostomy, and that all refers to the part of the colon where that colostomy is created. Another form, other than a colostomy, and the Hartmann's pouch, some folks can have a mucus fistula. So instead of suturing the rectum and leaving it be, some folks might need the part of that colon so this would be the part, instead of suturing shut, they bring it out to the skin as a mucus fistula, and then the colostomy where the stool will come out. This usually won't have much coming out of it except for mucus. Now, a diverting or a loop colostomy or a diverting colostomy is different from an end colostomy. That means a part of a loop from the colon is brought out to the skin, and then we open up an area of that colon here, leaving one spot out up top for the stool to come out, and the other spot is just connected to the rest of the rectum. So that's how a loop colostomy will look different than an end colostomy, because it will have two openings. Similarly, an ileostomy refers to the ileum that is brought out to the skin, and a loop ileostomy is a diversion ileostomy, or it's a loop of ileum that's brought out to the skin, opened up. It'll look like this, where you'll have two separate openings. One opening is from the proximal loop that brings out the waste, and the other opening goes in to continuity with the rest of the anatomy or the colon. As opposed to an end ileostomy, which is a part of the ileum that is cut because, let's say, the colon was completely removed as a total abdominal colectomy, and that part of the ileum is brought out to the skin, and it'll be a single opening out of the skin that brings out the waste or the stool. Specifically in patients with vascular EDS, there have to be specific in the operation and post-operative risks that the surgeon needs to keep in mind. Patients with vascular EDS have a higher risk of bleeding. There's also a higher risk of cervical spine subluxation when they're getting endotracheal intubation for the anesthesia. There's also potential risk for arterial injury during surgery or during a central line insertion. And after surgery, there are also risks of the wound dehiscing, meaning opening up and not healing properly, or causing wound infection, or the incisional hernia that Dr. Wang was talking about. Other risks could be risk of colonic fistula due to the thinness of the walls of the colon, and sometimes there might be some stoma problems, whether stoma prolapse or a leak from around the site of the stoma. And patients with vascular EDS tend to have severe intra-abdominal adhesions. Now, here I just took that from our ostomy nurses at Mayo with several ostomy supplies that can be used. There usually would have to be a wafer or a base that is usually placed around the stoma. And the stoma will be brought out from that hole. So this is usually cut to the specific patient's to the size of the specific patient's ostomy, and then it's stuck to the skin around the stoma, which allows the patient to attach this bag or pouch on top of their stoma. Other folks might have a bag that's directly attached without a wafer. So the bag will be directly attached with a barrier ring, and they won't be able to remove the bag off the wafer. They would have to remove the whole appliance and replace it. Usually, this is a discussion that is had with your ostomy nurses to decide on what the best appliances are for your specific case. And that's all I got for you.
Thank you so much, Dr. Wang and Dr. Chedid. I'm really looking forward to hearing now from the panelists as well as what their own experiences living with an ostomy are. So I will give each of you maybe a few minutes to share, a little bit about your background and your story and with an ostomy. So why don't we start with Darine?
Okay, so I got diagnosed about 5-6 years ago by my genetics doctor, and I had 5 perforations until they removed my sigmoid colon and put me a colostomy bag. I gotta say, the colostomy changed my life just because my life is surrounded with it. Like everything I do involves my colostomy, what I wear, what I eat, where I go. But at first it was hard because it's not something that you're used to, but after a while you get used to it. And I'm actually thankful for it because it saved my life. I've had it now for 2 years. I'm still waiting for the reversal. Hopefully it's during the summer or the fall. And hopefully it all goes well. Yeah, that's all I wanted to say.
Thank you so much. And we'll talk again after we give everybody a chance to introduce themselves. We'll have a discussion about what it's like living with an ostomy further. So I'm going to go ahead and jump to Aaron Sander.
Hi there. So yeah, my experience was I was diagnosed with VEDS about a year before I had my perforation. I had never had any sort of, I never really there was nothing that sort of showed any signs of it. My father had sort of spontaneously passed away about a year before that, and he wasn't diagnosed. The way I was diagnosed was just kind of a fluke. And then not long out, like I said, about a year after I was diagnosed, I had the perforation, and yeah, it definitely, I had the reversal. I was fortunate enough to be able to do that after about 9 months. And it was definitely a life-altering experience, to say the least. Even with the reversal, I have changed a lot of just sort of my diet, a lot of activities, just my just overall day-to-day has definitely changed, just for fear, I guess, of having it happen again, because it was spontaneous. It had nothing to do with anything that I was doing. It just kind of happened. And yeah, it was definitely a very it was an eye-opening experience, to say the least. I hope it, I know that it comes with the territory of possibly happening again, with us being sort of the lucky ones, if you will. But you just kind of take it day by day, and I lead a much healthier lifestyle than I did because of it. And so, hopefully that's enough.
Thank you so much, Aaron. I'm going to go ahead and jump to Heather Dixon.
Hey friends, I was diagnosed with vascular EDS in January of 2016 after a slew of major medical events that happened in the fall of 2015. It which included a miscarriage, a partial kidney infarction, and a carotid cavernous fistula in my left carotid artery, all of which had happened after about 6 years after my colon perforated in 2010. And so when my colon perforated, that had vascular EDS had kind of flown under the radar. No one really realized that it was connected. And so my colon actually perforated spontaneously again, like, Erin, I'm sure Darine will agree, like there was nothing, no trauma, there was no activity connected to it. It was just, I was walking out the door 1 minute and on my knees and the next in pain. And so, urgent care originally misdiagnosed it as, oh, we just have a stomach virus. And so I think, Dr. Wang, you mentioned this, like my small intestine covered it up, like twisted to cover the perforation hole up. And so I spent about a month before anything, was really wrong in terms of symptomatically. And then that turned into septic shock and peritonitis. And so, of course, I went into the ER and they found it under exploratory surgery. And then I was very fortunate to have it reversed 3 months later, all of which was happening before my vascular EDS diagnosis. So my experience with an ostomy was kind of pre-VEDS awareness. And I'm somewhat thankful for that, because I didn't have a whole lot of anxiety about that reversal surgery. I was just like, yes, let's get it done. And I'm very fortunate that it was successful.
Thank you so much. And thank you everybody for being here with us today to talk about this topic. I know it's a really personal topic, talking about living with an ostomy, and I appreciate your openness on this webinar here today. Can we talk about that reversal risk a little bit more? I know that was one of the questions that came in pre-live webinars. One of the pre-submitted Q&A questions was, for a young person, like this is a 4-year-old specifically who has had an ostomy and is living with one, what is the reversal risk like? And then I'd like to jump to the panelists too, specifically Erin and Darine, about how you are processing that like reversal risk. Like Erin, you already had yours, and Darine, you're moving forward with one. So I'm gonna go to Victor or Iris, and then Darine and Erin.
I'm happy to take that one. So there is reversal depends on what type of surgery we're talking about. If it's just resection of the sigmoid colon and having a colostomy and then reversal, there's a risk of leak around the site of the reanastomosis or of the suture. The risk is quoted somewhere between the 50%. It's what I'm seeing in the literature. So it is a high risk, but at the same time, as Darine has said, that she has initially struggled with living with the ostomy and it has affected her quality of life, and she's not alone with that. Many patients experience that, and with that being said, that when you come to your doctor, you can hear that number of 50% and you might say, it's a 50% chance, I will take that risk, or I am not willing to take that risk. I don't want to experience another perforation, or I don't want to experience complications from the reversal. So while the risk is high, it is on a case-by-case basis and a preference after all.
Thank you.
And I'll just kind of add that the data here is kind of lacking, right? There's
That's right.
Not really a robust body of literature to say that 50% risk is, very, and then the question is also, what are we talking in terms of reversal risk? Are we risking an incisional hernia? In which case, that risk is probably something that's very acceptable in order to not have to live with an ostomy? Or are we talking, a persistent wound and an infection? And I think we do not have a lot of data to say, it's 50% something bad is going to happen if you undergo reversal. That is not what that data says. When we talk about reperforation risk, that is irrelevant of whether or not we reverse, because even if you don't reverse, that reperforation risk kind of stands. And so we're not being very helpful because there's not a lot of data, which means we need more data. But what it also means is it really needs to be that individual discussion between you and your doctor and what kind of surgery you had, how bad your vascular EDS is, how much collagen defect you have, to really personalize that decision. You know, for some, living with an ostomy is better than not, but for others, there's a big kind of burden to it. So it's a very, very individual decision.
And I would assume, and I guess I would assume that it also has to do with probably your, I mean, you touched on it a little bit, but your history of issues. If you've had a lot of issues, you probably have more of an intense version of VEDS that probably the healing process isn't going to take as well. So, I mean, I would imagine that factors into how well your body is going to react to a surgery like that.
Absolutely.
So that 50% is almost more based on the type, because there's so many different types of VEDS that you can have, that it's almost more dependent on just person to person.
So I wonder, Erin, did that, like, what played into your decision to get the reversal?
I wasn't really, there wasn't really a percentage put on the issue of having a reversal. So I'll be honest, I didn't really even think of not having it. I have a history of, like, I think my, the version that I have, if you will, is, it's not great, but it's not the worst. I have a few aneurysms currently and some dissections and things like that. I had no prior history to any sort of perforations or aneurysm ruptures or anything like that. So for me, it didn't seem like, if I were to look at it now in terms of my history and how my body has sort of reacted in general to having VEDS, that because the issues that I've had have been somewhat minimal prior to the perforation, that maybe my collagen or my lack thereof isn't as high as some. So I probably have a higher chance of the reversal being successful. So I probably would have weighed out that in terms of deciding whether I was going to go about it or not. And then, so to me, it was kind of a no-brainer. I was just like, yeah, this is, I was waiting for it to heal enough basically with the colostomy, and then get to a point that my doctor said, okay, your body is ready to go through that again. Cause it is an intense surgery and the recovery is not fun. It was worth it for me in the end, but I think that's all. I think that's why when the 50% thing, I totally understand that in terms of having, because you want to put a percentage on it, but because it's just so dependent on person to person, that it's almost like you can't really put a percentage on it at all unless the data set that you're working with is so vast with all the different types of VEDS that you could possibly have in each one of those subsets, and then having what the chances of you being able to have that reversal be successful is like, it's a lot of research that would need to be had.
Yeah, I really appreciate that. And I want to come back later to, that impact of the ostomy itself, as well as the healing process. So we're not going to stop talking about that, but I do want to jump to Darine and ask the same question. So I know you're currently living with an ostomy and proceeding with a reversal. What kind of things are you thinking about?
You mean towards the reversal, or?
Yeah, towards the reversal, or any part of it, really. Yeah.
Well, for me, really getting the reversal is just so I can go back to somewhat a normal life. Maybe be more comfortable wearing my clothes again. Yeah. For me, I know the risks. My surgeon told me the risks of what could happen after the surgery, but I'm willing to take that risk just so I can go back to my normal self. And yeah, that's about it.
Do you want to touch on a little bit more, like how impactful that ostomy has been and in what ways? And I'm sure there's people listening or watching this webinar recording later that are really struggling with that.
Yeah, so I really had to stop eating a lot of the things that I liked, like corn or peanuts, anything that is a little, and also anything that is a little heavier. I started to eat very light, just because the after effects, the gas, you can't stop the noise that comes out of your bag, or if you go to the washroom, and you get sick from your food, your bag kind of like inflates and it shows through your pants. And wherever I would go, I always bring a bag with me in case I need to change, because I did have a few episodes where I was out and I had a leak that went through my underwear and my pants. So either I had to change there, or I had to rush home and shower and change. Yeah. Yeah, I think that's about it.
Yeah, that's a lot to go through, and that's a big change after that.
And yeah, and also you want to be intimate with your partner, and at first it's like you don't want to, because you don't feel good in your own skin. So I think it takes a long time for you to, well, for me anyways, to accept the fact that I had that attached to me, especially knowing that I have like feces really on me as I'm walking around, and it's just not something that you're used to. So I feel like all of these are the reason why I want this reversal. So I'm really hoping that the reversal goes well, because as a surgeon was saying, that if I get another perforation after the reversal, I'm gonna end up with the colostomy permanently, just because of my history of all my surgeries. So fingers crossed that everything goes well.
Thank you. We're crossed for you too. I think we all are crossing our fingers for you.
Yeah, thank you. Thank you.
Heather, do you want to speak to that, that feeling of like right after your surgery and that life change? Like, I think this is a really good topic to delve into some more.
Yeah, I think I can echo a lot of the things that Darine was experiencing. I had an ileostomy and I only had it for about 3 months. So in the scheme of things, it was a very small time frame. But surgery afterwards, I remember there was no what is expected. And so I think for me, the biggest piece of it was just dealing with the anxiety of, is this normal pain? Or is this something wrong? And, for, someone, obviously I had no idea that it was connected to vascular EDS, but still, I mean, it was a very, I remember my surgeon told me that the pain coming out of it, because of the way they had to slice through my abdominal muscles to redo the reversal, he said it's excruciating. And he was accurate in that description. And so I think just dealing with the pain and knowing, okay, is this normal? Is my digestive system working again? I can remember my son was 4 at the time, and I can remember laying in his room, putting him to bed and just laying on the floor, not being able to get up because I was so afraid something was wrong with my body. And so, just not knowing how to deal with that. I think, beyond that though, I mean, it was obviously liberating once that I allowed the time for my body to heal, and that just, not knowing that I had vascular EDS then, that takes more time for us with connective tissue disorders. And so, it took, probably where the doctor would say, 6 weeks, 8 weeks after surgery, it probably took me 3 months before I felt like, okay, my body is kind of normal. And then, post reversal, I know, a lot of people in the VEDS community, really, if they've had the reversal, or if they had an ostomy, they're very careful about what they eat. I am not, I can remember, okay, don't eat broccoli, don't eat chia seeds, don't eat, all these little things that can, get caught in things. But I really have been very fortunate. I don't have a diet that is affected at all post reversal. So I eat whatever I want. I'm thrilled to say I can eat eggs. I could not eat eggs during my ostomy because of the smell. It was just out of this world. And I love eggs. So, I eat those now. So, I think just giving your body time to heal is so important. And, recognizing that pain is, it's good to be very in tune with your body. One of the things that one of my surgeons said after my carotid was, after she repaired my carotid fistula, she said, you can have a normal life with vascular EDS. You just have to be really in tune with your body. And she's right. So I think it's just learning to listen to things that your body is saying, and taking time to rest and taking time to deal with, okay, this, prompted anxiety of something new, a new normal. And it's okay to give yourself space for that.
Yeah, I think that's really important too. It's like a physical healing process as well as a mental healing process, even grappling with this new thing on your body. Erin, did you go through any of that with your ostomy too?
In terms of my thoughts and feelings on recovering, yeah, it was definitely, I mean, the healing process from the reversal it's almost like you're experiencing twice, right? Like that first one to get the colostomy, there's for me, it took like 2 or 3 months to recover from that initial surgery. I think it's a little bit different, obviously, when you're also having an emergency surgery. At least that's what they were telling me. And then in terms of the reversal, I actually had to have 2 surgeries in the reversal within like 12 hours of each other, because the first time, I don't know if they didn't suture it correctly or something like that, but I was having a lot of blood flow that was happening through my now reconnected colon. So I had to have another surgery right after for basically them to go back in and redo the sutures on it. So mine was a little bit weird, or maybe not weird, but then that reversal recovery was another 3 months. So like to get sort of back to feeling mobile. So yeah, there's I mean, it's, if you think that basically out of, what is that? That's 15 months or something, that 6 of that was recovering from a surgery. And then, 9 of that was living with a colostomy bag. So it's a that those percentages are very interesting to live with, to say the least. So it was definitely a process in terms of the recovery. If it or in terms of the reversal, if it works, I mean, yeah, it's obviously worth it, right? Because you can kind of go back to what was normal for what you're used to in terms of what your entire life before that was. I will say that I was excited to get it, but there was a point. I don't know if you, and I guess I didn't have it long enough to fully get used to having an ostomy, but you kind of do get into this routine after a while of living with it for, a significant period of time, where Darine was saying, like, carrying around extra bags and having, 2 in your car and 2 in your office and 2 in your backpack. And you're just like, you've got all, and each bag is individually wrapped with Q-tips and the ostomy and the guard and the bag, and they're all wrapped. It's just like, you basically get into this whole new routine. And then there's all the different clothing and bands that you can get. Like, there's a whole accessory market that you get into. So it's definitely like it's an overwhelming process to go through to sort of get used to what this new normal is, because it does very much affect your day to day. And if you can have the reversal, great. But if you can't, I mean, then, it's just kind of your new normal. You can have a normal life with a colostomy bag. It's just a new normal.
Yeah, well, go. I see Dr. Wang is unmuted. Go ahead.
I want to comment on how wonderful it is that there's this community and this experience, right? For anyone listening now or will be listening to the webinar. I mean, it is just so important to give yourself a little grace when this happens, when something so big, such as a perforation, happens. I mean, I have, unfortunately, I see a lot of folks who don't give themselves that grace, who then become so concerned about what they are feeling that things can really spiral out of control. That what Heather was sharing about not understanding or not having any guidance on what pain is normal, right? And when you should be worried and when you should be not, that can really lead down to this rabbit hole of everything being concerning, of being hyper aware of pain. And that's sort of how chronic pain starts and chronic pain develops. And so this is so important for folks to hear that the pain is expected, but that it will get better, that it can get better. And talking to resources like you guys who've gone through it can be so helpful to help, much more than a physician, much more than me and Victor, to help get through the day-to-day and understanding your body. And, forgive your body. It's still there. It's still helping you. It's still doing what you need it to do. But like Erin is saying, it's a new normal.
And by the way, what Heather said is exactly right. Like your body does tell you when something is wrong. And usually it's like I go through these things where it's like, I have a stomach ache. What is this? I moved something heavy the other day and I literally felt nauseous for 4 days after it because it was something that I shouldn't have lifted by myself. And I knew it when I was doing it, but I was like, oh, it's fine. So like, but it was one of those where I was like, did I just did I just weaken my abdomen this way? And am I going to have an issue? You definitely go through mental backflips with it. But when there's something really wrong, your body is going to tell you, and it usually gives you, there's no formula for this, but usually you can there's something intuitive about it where you can kind of go, okay, there's something really wrong here and I need to go get it looked at. And sometimes there isn't anything, but those little aches and pains that you feel, you start to just sort of get used to because your body's just a little bit weaker than it normally, or it should be, from doing things that shouldn't make your body feel that way. But when there's something really wrong, you're going to know.
Yeah. Can I piggyback on that a little bit? Thank you so much for chiming in, Dr. Wang, about that and just echoing that, because I want you to hear the words. These are not my words. This is the words of my ostomy nurse. When I woke up from exploratory surgery, when they found the colon perf and they had put in the ileostomy, and I woke up, with staples down, my stomach and the ileostomy bag. And I had been in a coma, a medical induced coma, for about a week. I had no idea what was going on. And I woke up and one of the first faces I saw was my ostomy nurse. And she just had this gracious smile on my face. And I love that you said the word grace, Dr. Wang, because she said, you have permission to grieve. And those words were so liberating for me because, she just said, you have permission to say, this is not okay. And you have permission to take the time and deal with this and, sit in this new normal. And so I think that's important for all of us to remember and not skip over into the heroics of, I'm going to, figure this out and I'm going to power through this. And we will, because we're human. And, I love my body is broken, but I love my body because it's strong. And, and it's seen me through so many moments of crisis. And I thank that every day, that look, we've seen some stuff together, you and I, body, but, we're doing okay with that. In her words, I never forget, they were so empowering to say, you have permission to grieve. So if that's you, if you're in that space, take the time to say, look, this is not the way that I expected. This is not the way that I thought it was going to be, but it's going to be okay. And I'm so thankful to Katie and to all of you here, because we didn't have this, in 2010 when I was dealing with this. I felt so isolated. There was, no one with these stories. So just the advancement of medical research and advocacy for vascular EDS in those 12 years is astonishing. So all that to say is that there's hope coming. So just cling to that, my friends.
I really hope that somebody listening to this really hears what you just said, Heather, that it's okay to grieve. I think it's so important that I think I said it earlier that, sometimes we forget about this like mental recovery piece of it, but I think it's so important to not acknowledge that. And so if you're listening to this and like you're joining this because you're struggling with living with an ostomy, like you aren't alone in that. You have 3 people here who lived with that, experienced that, struggled with that, continue to live with an ostomy, and there's a lot to go through. It's a lot to allow yourself to deal with that. Darine, do you have any advice for somebody living with an ostomy that's kind of struggling with that too? Or, anything that you wish that you would have known when you first got your ostomy?
I think just taking care of it. When I first started, my ostomy would maybe last me 2 to 3 days. And now I'm able to extend it to 7 days just by taking care of it and cleaning it. And I shopped around a lot to find the perfect one for me. There's so many different kinds out there of ostomies and the barrier tapes and all that. But the good thing is that I found is that they all give you free samples. If you call all the companies, they'll give you a free sample before you can pick whichever one you is perfect for you, and then you can purchase them. And the more I lived with that, the more I found more companies, more different products that I can use. Yeah, I think that's it. I just do your research. Does
Oh, you went on mute, Darine.
a website, and he explains very well into detail with videos and brief descriptions of different types of things. So I found that very helpful.
Which website was that? You cut out there.
Vegan Ostomy.
Okay.
Yeah.
Awesome. Thank you so much.
You're welcome.
We did get another question before this webinar started about bleeding when you're changing your stoma. And the question was, how do you stop the bleeding on the stoma while changing pouches or cleaning it? The person who submitted that question really has a problem with that, and then it starts bleeding, it doesn't stop. And anybody that had an ostomy, and even, you know, Victor and Iris, if you have any recommendations you give to your patients, I'd love for you to chime in.
I'll take that one first, because I did have that issue with just skin sensitivity around my stoma and within my stoma. I don't remember if this advice was anecdotal or clinical, but when I started, and Darine, you can probably chime into this, and Aaron, you too, but you know, when I started changing bags, I ate a lot of marshmallows. I don't know if that's a thing, but it was supposed to help slow your digestive process down, because my, you know, problem was I would try to change the bag, and, you know, the output of the stoma just wouldn't slow down. And so marshmallows, for some reason, really helped for me, and it gave me time, because I was not a very quick bag changer. It gave me time to deal with all the cleanup and the bag change. And then a nurse gave me this, it's V. Mueller Whisk Adhesive Remover. Yeah.
You can see it.
Yeah. Okay, good. And so I would put that in when I was changing my bag, because, you know, if you have vascular EDS, your skin is incredibly fragile and just prone to tears. And so I'd put that on a little Q-tip and kind of ease that around the bag when I was pulling the barrier off. And then before, you know, when I'd clean it, and then to put it back on, I use, and Darine, just your vegan ostomy site may have all of this and more, I'm sure. These were what worked for me 12 years ago. So this Cavalon No Sting Barrier Film, it comes in these little wipes that, you know, that I would just wipe around. I would take 1 or 2 of those and wipe around my stoma. And then I finished that off with the stoma adhesive protective powder. And the 3 of those together worked like a charm for me. I didn't have any issues, didn't have any skin breakdown, no ulcers on my skin after that. Before, it was a nightmare, but after those 3 things together, it really helped.
Thank you. And Victor or Iris, do you want to chime in? Are there any other tricks that you hear from your patients? You're dealing with that?
I usually always defer to my really excellent ostomy nurses. for that. And I always tell my patients, make sure you partner really well with your ostomy nurses, make sure who your contact is, because they always have excellent tricks, whether for peristomal bleeding around the ostomy, or the tricks that Heather just shared, because the bleeding can be from so many different reasons, whether it's from skin breakdown, or if there's some leakage around it and that's causing bleeding, or whether the adhesive is not the right type of adhesive for that particular patient, if whether reacting to the adhesive in the wafer, or whether it's really tight around the stoma and they need to loosen it. So there are so many different reasons why somebody might be having bleeding. And that's where I would partner really well with my ostomy nurses to help determine the best tricks.
Yeah,
And I'll just kind of add that, you know, it is important to identify where that bleeding is coming from. So if it is coming from periostomy, then definitely kind of barrier creams are the way to go. But if it is coming from kind of the intestinal tissue itself, that's when physicians are useful, right? The other stuff physicians are going to be less useful, but identifying whether this is an intestinal bleed, maybe an artery or something, or some abraded tissue that we treat in clinic, that we need to do something to cauterize and stop the bleed. So kind of, and this kind of goes back to knowing your resources, you know, and when a physician is more useful, when your ostomy nurse is more useful, when your community is the most useful, to help share those resources from shared experience. Because honestly, there's only so much we can learn from studies and from a textbook. There's nothing like lived experience.
Thank you so much. I really appreciate that. And I love that like highlight of how the community can really help somebody else dealing with this. I think that's one of the beautiful things about our VEDS community is that we are, you know, so connected with each other that there are these opportunities to ask other people, and even more so now with the VEDS movement and the Help and Resource Center that we have with our registered nurse. You can reach that at thevedsmovement.org/ask if you have a question to follow up with there. And our nurse Jan there is really helpful in trying to find those answers. But resources like these, I think, are so important. So I'm so appreciative that you highlight that and give our community more of a voice. So helpful. So that's the end of our Q&A that we got ahead of time. If you're listening in tonight and you have a question for Darine, Aaron, Heather, Dr. Wang, or Dr. Chedid, I'd love for you to put it in the Q&A box so we can address it if we can. And until we receive any questions in there, I'm just wondering, is there anything on your mind, either Heather, Darine, or Aaron, related to your ostomy experience that you haven't shared and want to touch on more?
I mean, just know that it sucks. It sucks. It sucks for everyone. Like nobody is having this experience where they're like, oh, this is fine. Like it's like, it is a shock to go through something like that. And that I mean, I didn't realize until it had happened. And my wife is a crazy researcher, that there is a whole community out there, whether it's message boards or Facebook groups, or there's a lot of people out there that are great resources to either talk to an actual person, to find different products that'll help you with your ostomy. Like I had a lot of irritation and things like that, and the ostomy nurse that I linked up with was amazing and an incredible source to be able to utilize, because physicians can sometimes be hard to get a hold of, and usually that first line of defense of using that ostomy nurse is a great resource. And if there's something that needs to be elevated to a physician, then they're more than happy to do that for you, and help maneuver you to whoever you need to speak to in order to get an answer that you need to. But I mean, if you can figure out your own path if you choose to sort of really do the research and and connect with people when you need to. I mean, I was the only person that I had ever met that had anything like this before. So it wasn't like there was a whole community around me that I could just, go reach out to. It's like you do have to do a little bit of research. It doesn't actually take as much as you would think. It's just like, the internet's a crazy place that you just Google stuff and you can go down the rabbit hole of all sorts of crazy YouTube videos and tutorials and all sorts of things that are really, really useful, like exceptionally useful, that also show you that the things that you're going through aren't abnormal, that whether it's, your mental state or physical state, that these are all things that somebody has already experienced and probably is okay talking about, and that those experiences are on the internet that you can read about. But yeah, don't, whoever it is, if you're out there and you're going through it, know that it definitely sucks. Like, it is not fun, and you just kind of get used to it and you get into your routine. And then, I don't know, for me, eventually I kind of got to a place where I felt almost stronger because of it, because it's really going through a lot. And if you can sort of, really grab it and own it, then, it's an experience that not a lot of people are going to be able to experience, and that a lot of people find fascinating, because it is such a different than quote unquote normal thing to go through. But it's not fun, and you do have to sort of get used to it. But eventually, if you can really ride it out and sort of get used to that new normal, then it's just like any other routine that you're going to have to go through.
Also, I found there are many Facebook groups for EDS, and I've joined all of them, and the people on there are really supportive. And we all go through the same thing. So if you always want advice or, help with anything, or just support, someone to talk to, they're all there for you. We're all in this together. We're all going through the same things. Maybe not like the exact same thing, but the same experiences, really. So yeah, there's many Facebook groups that you can join, and they're amazing. I'm on them all, so yeah.
You end up meeting some pretty incredible people.
Yeah, I agree. I met, actually, from these Facebook groups, I've met 2 people from Ottawa, 3 actually, that have EDS, not the vascular kind, the HEDS, but still EDS, and they're from Ottawa. So, I mean, that's pretty cool. I thought I was the only one here. Yeah.
That's awesome. And it seems like, we see more people now from Ottawa and Ontario as a whole. So it's really interesting to see our community grow, and hopefully eventually we'll be able to connect you with somebody with VEDS too, Darine and Ottawa. That would be incredible.
Yeah.
Is there anything that you didn't share that you would want to share?
I think just the acknowledgement that you are not alone in this, and we've kind of touched on that already, but just that reminder, I think, it's for me, I really struggle with anxiety dealing with vascular EDS. And I think that, you don't deal with an incurable genetic disorder and not become BFF with anxiety on some level. At least in my world, you don't. And so, I think just the reminder that, you're not alone, and it's okay, and reach out to someone if, you're struggling with this, and, you feel like you're isolated and no one else has this experience. That's not true. VEDS manifest in different ways for different people, but, there are people who have walked this path. And so, just a reminder to give yourself, again, space, give yourself permission to grieve, give yourself time to rest, prioritize rest, prioritize taking care of your body. And I think for me, the knowledge that I have vascular EDS in a lot of ways has saved me from probably, so many potential major medical events that I would have no idea of going forward. And so, that's a good thing. And so just the reminder that, you're not alone. We are all rooting for you. Like Darine said, and Aaron said, it's a community of just, these really wonderful vascular EDS warriors. And that, even though it may seem rare, advocacy is changing so fast. And it gives me so much hope. I mean, I remember when I was diagnosed, I thought, oh, maybe, when my son's generation or his kids, maybe there'll be some change, but I don't think so, you guys. I mean, I think it's really going to happen so much quicker than than I would have expected before that, because of all the fabulous work that the VEDS movement is doing, and Dr. Wang and Dr. Chedid, and everybody that's involved in this. I mean, that's good news. And just I found it funny, just on a personal note, Dr. Wang, in your message, you mentioned the Cologuard for colonoscopy alternative, and I'm of the age where I need those sorts of things. And so today I actually had my annual, and so I have a Cologuard test coming in the way. So I'm really, really thankful that that's an option. I mean, before it was just like colonoscopy or bust, and I can't have a colonoscopy. So I'm really thankful that that's an option. So all that to say is that it's this isn't the end of the story for vascular EDS, friends. There's good news coming. So thanks to all of you who do such amazing work for our community.
Thank you. This would be such a beautiful place to end this webinar. And I feel like whoever's listening is probably going to be like, come on, Katie, just, that was a beautiful place to end. But I did have a thought, something that we did not touch on earlier from our community members. I think it's important to touch on for anybody listening to this who has not had a bowel perforation and is worried about recognizing what that feels like. We talked a little bit about the anxiety, like, recognizing regular pain versus irregular pain, and something that is really a concern. And I think, I think Iris talked about this in her presentation, the signs of a bowel perforation, but I would love to hear from each of the panelists here, what was your experience in your own words? Like, what did that feel like to you if you were going to explain it to somebody who might be watching out for something like that?
So for me, I've had 5, and I gotta say, the last one was the one that hit me the hardest. I was at work and I was fine. And then after lunch, I just felt like really bloated, like I needed to pass gas. And so I went to the washroom, but nothing came out. And then before I finished lunchtime, I was really hungry around 10 o'clock, but then when noon came, I was not hungry at all. And then I had lost my appetite. And then closer to the end of lunch, so around 1 o'clock, I started to have that bloating. And then so I tried to go to the washroom, and then nothing came out. So then I just dealt with it. And then a half hour later, I remember I was with a patient, and then I couldn't, the pain just started to, it's like a cramp that just evolves. And then after a certain point, you're in pain of just standing straight. I was hunched over, so I had to go sit down. And then I thought maybe a hot pack would help, but it didn't. So, and the pain just started to get worse and worse. Next thing you know, I was like sweating. So then that's when I knew that I was having another perforation. So then I rushed to the hospital, and then they didn't take me in right away. I was waiting in the emergency room, and then I started to become a little green on my face, and I felt like I was going to pass out. Like the more you wait, the worse it gets. And then at one point, you're not yourself. You're like, you change color, you can't stand. I couldn't even talk. I couldn't even breathe. But yeah, no, it just started like a normal cramp that just evolved. So you would know it's a pain that you don't feel on a regular basis. Yeah.
So it's like a different kind of cramp that just.
It's like a cramp. It's like someone like stabbed your stomach, like a shooting pain, very shooting pain. And then your stomach just bloats up, and there's nothing you could do. There's no gas that comes out. There's no, you don't have a bowel movement. There's nothing that comes out. Yeah.
Yeah. Erin, what was yours like?
Mine was the day before I started feeling just sort of nauseous. I just wasn't feeling, I was just feeling off. A little bit of a loss of appetite, but just like, like just kind of crummy, nothing like debilitating, just not great. And then the next day, so I got on it. Let's see, that was that day. Then the next, I don't remember if I waited 2 days or a full day of the nausea, but I think it was, I started feeling I started feeling nauseous, and I got on a flight the day of, and it was getting a little bit worse, but it was still just uncomfortable. And then the morning that it happened, the pain started to sort of set in. I went and had breakfast with my in-laws. Had a bowel movement. It seems like my body seemed like it was functioning correctly, but the pain started to just sort of build a little bit. And then after breakfast, I was like, this is hurting a little bit more. And I didn't really know why. And it was consistent. It wasn't going away. It was just persistent. And then I decided that it was like, I had an appointment to go see. My story is so serendipitously weird that it ended up being the way that it was. But I had a doctor's appointment to go literally that day at the hospital. So I called my doctor and I was like, I'm not feeling so good. Can I come in early? And they're like, yeah, sure. So then as I got there, I started feeling worse. And then similar to Darine, it got to the point where I was having trouble just standing without being uncomfortable. And that pain just again, slowly getting worse and worse and worse. And then I got to a place where I was at the hospital and I could barely walk at that point. And they're like, okay, let's go get a CT scan. So they wheeled me in a wheelchair down to the emergency room. And at this point, I'm like hunched over in the wheelchair because it was like the pain was getting to that place. And then I was in probably the emergency room, in the waiting room for 10 minutes. And my wife was next to me. And I just started the color gone from my face. I looked at my wife and I was like, something's wrong. And I just blacked out. And then that's a really quick way to get a room in an emergency room, because passing out in the hospital. So they wheeled me right in there. And that's when they, EKGs, and then they had to go through the whole, figuring out what was going on. But it was definitely one of those things where it was more progressive for me. It was like a 24-hour probably period in terms of that feeling a little off and nauseous to actually getting there. But it was definitely something where it got to the point where you were like, probably a couple hours before, that something was wrong. Like it was to the point where I had enough time if I needed to get to a hospital, knowing that there was something that was off.
You could tell okay, at this point, you felt off for a while, but at a certain point it became something you could not ignore.
If things are only getting worse and it's not getting better, then there's probably something wrong. Like you can give yourself, and then if it continues to get worse to the point where it's debilitating, I was hunched over and doubled up in pain and things like that, then something's wrong. Like your body's literally telling you, hey, I'm not getting better, I'm getting worse. So help.
Heather, what was yours?
So mine was sudden. I was getting my son ready for preschool, and I put him in the car and I came back in the house. He was 4 at the time. So I put him in the car, came back into the house, and I can remember walking back in to grab my purse and just dropping to my knees on the floor because it was just sudden pain. Just like pain, like you said, like Darine said, just stabbing, never felt this kind of pain before. This was not a menstrual cramp. This was not an IBS cramp. This was just bring me to my knees. And so, stubborn fool that I am, I got in the car and drove my son to preschool. And I can remember sitting outside of preschool thinking, I'm going to have to call his teachers and have them come get him because I don't think I can walk to walk him in. Stubborn fool that I am, I did walk him in. And I got back in my car. I took about 10 minutes to walk him in. And then I got back in my car, drove to work because I can power through this, right? I threw up on the way to work. And so I called in sick and I said, I'm going back home. I've got a stomach virus or something. I went to urgent care. right around the corner, which of course doesn't have any major diagnostic scans or testing capabilities. And she said, you work for a school, you've got a stomach virus, here's some Zofran, have a good day off. And I rested the rest of the day, and it kept cramping and coming in waves. But then after about 24 hours, I felt fine. And again, we know now in hindsight, that was when my small intestine was twisting to cover up, the hole in my sigmoid colon. And I mean, this is just a testament to adrenaline and, our bodies. But this was in November. I went through and hosted Thanksgiving at my house with a leaking, perforated colon. I hosted my son's 5th birthday party. I went through the Thanksgiving holiday, managing all of it. And then about a month, almost exactly a month later, we had taken my son to his hockey game in the morning. Everything was fine. And by the time we got home by lunchtime, we ate lunch. I could not get up out of the chair. It happened just like that. And I told my husband, I said, you're going to have to carry me. I can't move. Something is wrong. And so that was when, I was going into septic shock at that point. And so, it was nausea, chills, sweating, just absolute, I thought I was going to die in that moment. And then of course they took me to the emergency room and they figured out, we need exploratory surgery, but that was what my experience was like.
Thank you so much. Victor, Iris, would you like to add anything to that from a medical perspective?
It's really hard to summarize an individual's feelings, right? And so I'll caution the other way, perhaps, that I don't want anybody to live in fear of a perforation, right? Like this is often not something that's preventable. And so having the anxiety about it is not going to help either way. I think what I'm hearing Erin, Heather, Darine say is your body will tell you when it's time to go, and please listen to it. Please don't ignore your body when it's giving you those signals of, I shouldn't be walking my son into school, or there's something wrong right now. And it's really hard to balance that with the IBS pain, the cramping pains that do come, right, that are associated with these conditions. So I think it's a little bit of making sure that you're familiar with the sensations that are normal for your body. Don't catastrophize those, but pay attention when something changes. Trust your body to tell you, and then don't worry about it.
I love that advice. I really appreciate it.
And also erring on the side of caution a little bit, right? Like if you're hurting, then like go get looked at, even if it's just to an urgent care or to your GP or like somebody to like describe something. It's like, especially if you have the diagnosis of VEDS. I feel like it's, where Heather gets into trouble is that she didn't know she had VEDS. I guarantee you, if she knew she had VEDS and she was going through that first bout of pain, she absolutely would have gone to the hospital. It's like, once you know, you got to look at that as like a gift. It's like at that point, you know that your body is a little bit different. So if you're going through it, that nobody should be in chronic or constant or debilitating pain,
Absolutely.
Healthy or unhealthy. So if you're feeling it, go do something about it.
But to that end, right, don't let anybody take any organs out until you're absolutely sure that that's necessary, right? Especially because you have VEDS and the rates of complications, gallbladder surgery is no longer just a gallbladder surgery, right? So knowing that you have VEDS, yes, pay attention, err on the side of caution, but err on the side of caution the other way too. Don't just, I have right upper quadrant pain and somebody told me to get my gallbladder out. I'm harping on the gallbladder. It's a very special organ to me. But get that second opinion, right? Make sure that physician really understands your VEDS and the risks, involved in that surgery, because it's not just anything when you have VEDS, right? I am sure you guys know that it's never just something.
Surgeons want to do surgery.
Yeah.
Like when they discovered that I had like a right carotid aneurysm, I went to one of the leading vascular surgeons in the country. And the first thing he said was, let's get that handled. Let's get a stent in there. Let's schedule that surgery. And I went and got a second opinion, and that second opinion said, don't you dare go in there. That is a huge mistake. And like, it's not, and and then you figure out, you got to be your own advocate, and the medical system is a very, very hard thing to navigate, because there are so many different personalities and agendas, and it's not as simple. It is a business, unfortunately. So you do have to really like get the information and internalize that information and make the right decision for you. Sometimes surgery is what's required, but yes, as Iris said, like surgery for somebody with VEDS is it's different. Like the precautions that you have to take in order to have more routine surgeries that would be totally fine for somebody is not the same for somebody that has VEDS. It's just not. You can't have an arterial line. You can't have like if you're gonna, like, there's all sorts of things. So know the information on your condition, and then weigh out like what surgery is and especially what surgery would be like for somebody with VEDS.
Right. And I think I think that's a great place to end here tonight, because I think there's an opportunity to really get connected with the experts and like have an expert, like there's value, I mean, in having an expert kind of help your local care team. Like it's so important to set up a care team that works for you, and also to have an expert kind of in the know and advising that team and giving insight on those questions. What are the recommendations your local team is giving you, and how are they different for somebody with VEDS, or what kind of information does that expert have to inform that team on, what kinds of things might be important to consider. So I'm going to share my screen. We are like at the end of the hour here. Where is my, I've lost my presentation. I'll just share this. So, here we are. So I wanted to remind you again that we do have the Health and Resource Center staffed by Jan Lynch. She's a registered nurse. She works with the foundation and with the VEDS movement and all of its divisions. She's an absolutely amazing human being, and she does have access to a lot of those answers to those questions, and access to the experts to help get your questions answered. I mean, so if you have a question like this and you don't have an expert advising your care team, and you want that kind of input, or even just a pointer to where to even begin finding our resources and things that could help you, Jan is an incredible resource. You can reach her at thevedsmovement.org/ask, or through marfan.org/ask, or Louise Dietz Foundation.org/ask. They all lead to Jan, and Jan is incredible, and we absolutely love her. So I really encourage you to reach out with your questions to the Health and Resource Center. We didn't touch on this today, but I just wanted to let you know that it is coming up. Our E3 conference, the Marfan Foundation's E3 conference in Newport Beach, California, is July 7th through 10th this year. We're really excited to get together with all of our VEDS community and our broader Louise Dietz and Marfan and related conditions community. And we'll have medical presentations. There's a health fair. There's a lot of social groups and opportunities to connect with other people who are going through what you're going through. So you can find more information about that at thevedsmovement.org/E3 conference. That will lead you to the conference page, and you can see all the sessions and all the details. The hotel information is there, and I hope that you decide to register and come and join us in California. It'll be a wonderful time to get together in person. Some questions came in before this webinar about the upcoming clinical trials for VEDS, and we did not touch on that during this webinar because that's not what this webinar was for, but there is information available through for A2 Biopharma through preventvedstrial.com. And then the other trial coming up is the Discover trial, and you can get more information from Acer Therapeutics at discoverceliprolol.com. We will also have a session about each of these trials coming up at the E3 conference if you'd like to get some of that information in person. And of course, the VEDS movement will provide you with updates as we get them, as they become available. It's a really exciting time for our community to have clinical trials kind of on the horizon. So it's a wonderful time in all of the directions for VEDS right now, really improving everything out there for us. So thank you for joining tonight. This webinar was recorded and it will be sent to you wherever you registered, whatever email you registered for. And thank you for joining us. Thank you to the panelists.
Katie.
Thank you.
Thank you, everybody. Really grateful to have you as panelists tonight.
Oh, it was our pleasure.
Thank you.
Thanks so much for having us, Katie. Thanks for all
Yeah.
you're doing.
Yeah,
Thank
thank you, Katie.
Bye, guys.
Bye. Have a good night.
Bye.